So Michael, that kind of gets to a larger conversation around what we consider tolerance to therapy. What are our goals for treatment? How do we assess quality of life? And how do we integrate that into the approaches that we give? Can you give us some thoughts in terms of this plethora of agents that we have available, how that plays a role in choosing agents and designing a paradigm for an individual?
Sure, yeah, and I think, so on the topic of tolerance, I think it's abundantly clear that not all patients tolerate these drugs the same. And for the most part, we're doing flat dosing right off the bat. With the exception of axitinib, there is a dose escalation. So a 105-pound woman may tolerate these drugs much differently than a 250-pound man. You did raise the issue of kind of goals of care, and I think that's a really interesting topic that's been somewhat explored, but we could really go deeper. If you ask patients, what is their goal, different patients have a different balance between prioritizing quality of life versus tumor response variables or outcomes. So I think, it's important to understand that patient's goals of care, to understand, what therapies you're putting them on. And I think, certainly acute supportive care is necessary to manage some of the side effects like diarrhea and so on and so forth. But I think one thing we're realizing is that as patients go into second, third, and fourth line therapy, there are some common themes, and one of those is fatigue that's going across all lines of therapy. And I know we've all had patients who've gone through 5 lines of therapy and they wind up in a wheelchair, possibly somewhat from the tumor, but I would also argue from some of the therapies as well. And I think we could do better probably with addressing lifestyle changes early on, whether it's nutritional strategies, exercise strategies, to try to mitigate some of those things like fatigue.
And David, at USC, give me a sense of what the conversation is with the patient now that we have survival data.
Right.
And we're not talking about either response rate or progression-free survival endpoints that may be important to the oncologist but not as important to the patient. So how did those conversations go?
I think the conversation has evolved recently fairly significantly. So we've always had the risk-benefit conversation. So what are the risks of you getting side effects that are going to be significant versus us controlling your disease and prolonging your life? And we've not demonstrated overall survival definitively until very recently with the 2 trials with nivolumab and also with cabozantinib. And so I think it is a different discussion. And from that perspective, I think that many patients still get into the paternalistic stuff of saying, well, look, I'll take the medication and I really don't need to have the discussion, just tell me what I should do. And throwing the stuff out there to say, look, there's a balance here. We may make you in some cases sicker than you really need to be. And the treatment may be worse than the disease. So telling them that, I think, kind of puts them into a position where you can have that therapeutic discussion. What's the balance when we're seeing you now? We're controlling your cancer based on the scan and your symptoms from the disease, but what are your side effects and how do we balance that out?
And Eric, just to make sure that our physician colleagues, what are your thoughts around when to start? We have this concept now that's been reported of so-called active surveillance when we know the cancer's there, we know the person's had a distant nephrectomy, the biology of the cancer may be slow growing. Some people think you should start immediately, some people you think you should wait. Where do you come down on that conversation?
So there is a couple of abstracts this year at ASCO that's sort of addressing that. And we do have data at this point in time that suggests that it's probably safe to wait, especially if you have an individual who has perhaps a small number of lesions, who have slowly growing disease, who have excellent performance status. So, and especially an individual that really is averse to any type of side effects, we can probably safely watch these individuals. So this is a strategy that I certainly employ with some of my patients. And I think the community can be comfortable after having a conversation with the patient, getting an idea of whether or not the patient wants to do that.
So David, let's kind of zoom in on this concept of active surveillance in kidney cancer. Not something that we've thought a lot about. Everybody thought over the years, once you find it, you treat it.
Right.
And we're learning now that may not be necessary. So what are the criteria that you use? Do you use any of the IDMC or Mozart criteria? And how do you decide when a person should or shouldn't be treated? And then how do you follow such a person over time?
So we now have some data that helps us. So Brian Rennie did a study led from the Cleveland Clinic that we were involved in, where we looked at active surveillance in selected patients. And what was clear was that patients who were particularly good risk, also intermediate risk, based on Mozart criteria or Heng criteria, could do well, especially if they had pulmonary metastases as their major site of disease. So I think this provided some surety for that discussion we can have with the good risk patient with pulmonary metastases to say, you may not need treatment straight away. We have another study that's being presented here at GU ASCO 2017, where active surveillance has been looked at from a different group. And they've looked at change in tumour burden and chance to progress, and it appears that similar factors predict. So I think you can talk to a patient who's presented with their first metastatic disease, and the messages are it's okay to observe them off therapy for a period of time. That will depend on their comfort zone, but they do need to be watched for potential progression. And I think it's important to set up a contingency plan with those patients about what you're going to do if they progress and we think treatment's needed.
So other than the lung-dominant, small volume patient, are there patients that you unequivocally would not follow actively without therapy? Categories of patients?
So I would be concerned if they presented with, for example, liver metastases, a solitary brain met that's treated. I will sometimes follow if there's no other disease, solitary bone met that's definitively treated. But they're riskier groups, I think, is the issue. And I think that's okay. You just need to talk to the patient. The ones that are difficult for me are the ones that are lymph node predominant. You know, they've got a whole bunch of lymph nodes in the back of their abdomen and mediastinum, and they seem to vary a lot. Some of those are fairly quiescent over a long period of time. Others, you know, you wish you had it done the next scan earlier because they can progress rapidly. So it's not necessarily the conventional group that we thought. And if I'm going to give that patient a first-line therapy, I'd like a game changer. So I will talk to them about immunotherapy in the first line if that's appropriate for them. Because while they've got these small nodules, if they live long enough based on their other health, they're going to have issues with this, and they may want to try a short period of therapy that changes their outcome with perhaps interleukin-2 or maybe some of the newer immunotherapies that are coming through on trial.